This is a general overview of the cardiac cycle. This is what happens when you have atrial contraction versus ventricular contraction. When the SA node fires off and you get depolarization of the SA node, which sends out those signals to the cardiac myocytes within the atrium, then you're going to have atrial contraction when the atria depolarizes. When the atria contract, you're going to have blood entering from the atria into both chambers of the ventricles, either right or left ventricle. And then during ventricular contraction, there's going to be two phases of ventricular contraction. And I'll tell you why that's important in a moment. But the first phase of ventricular contraction, the ventricles are beginning to contract, but the pressure is only strong enough to close both the mitral valve as well as the tricuspid valve. Those are your atrial ventricular valves. And then those are going to close, and that's called isometric or isovolumetric contraction. Isovolumetric meaning there's the same amount of volume within those chambers despite the actual contraction taking place. So the volume isn't changing yet. Then as the ventricles contract even further, getting into phase 2 of ventricular contraction, that's when you have enough pressure to actually open up both the pulmonic as well as the aortic valve. That's when you get phase 2 of ventricular contraction. That's when you actually get blood pumping from the ventricles into both the pulmonary trunk as well as into the aorta. By the way, when you have isovolumetric contraction, that's when every single one of the valves are closed. The mitral valve's closed because you have that pressure buildup within the ventricles, but the pressure is not enough to open up those pulmonic or atrial valves. And so those valves are also going to remain closed. And then at the very end, you have ventricular relaxation. And when the ventricles relax, that's when you enter into diastole. And that's when blood can passively enter into the ventricles from the atria. So let's talk about that whole entire cycle in a little bit more detail. So in the beginning, you have systole. And systole is going to begin right up here. It's when the sinoatrial node actually fires off. Okay, that's going to be the very first phase in the cardiac cycle. So you have atrial systole. And so the atria contract, allowing blood to enter into both of those ventricular chambers. And then the atria begin to enter into diastole, right, which means you have atrial relaxation. And then that's when ventricular contraction begins. So now you have ventricular systole, which is going to be subdivided into a couple different phases. The very first phase is when you have, the mitral valve and the tricuspid closing, while the other valves are also closed too. Both of those semilunar valves remain closed. There's not enough pressure yet building up. Then once that ventricle gets into phase 2 of contraction, that's when you get those semilunar valves to finally open, where blood can finally leave those ventricular chambers and into the pulmonic as well as into the atrial aortic system. Then finally you have ventricular diastole. That's when you have ventricles beginning to relax. Again, during that period, you're also going to get every single valve closing. So you have now reduced pressure within the ventricles. You have more pressure now in both the aorta as well as in the pulmonary trunk. Because of that increased pressure in the aorta and the pulmonary trunk, now that blood is going to push back on those semilunar valves, and those semilunar valves are also going to close. Then you have late diastole. And during late diastole, that's when the ventricles basically just fill up passively. They're going to relax completely during that diastolic phase, and then blood is just going to passively fill in to those chambers. And then the cycle can begin all over again. So here's that little question right there. When do all valves close? There's going to be two sections during the cardiac cycle by which those valves are all going to close at the same time. The very first time that happens is going to be right over here. That's going to be the first phase of diastole, of systole. Okay? That's when you have just enough pressure to close the mitral and tricuspid valve, but not enough pressure to keep those semilunar valves open. Then you have that full contraction, right? That's when you are able to actually pump blood into those, right through those semilunar valves, into the pulmonic trunk as well as the aorta. And then once you get into early ventricular diastole, that's when all those valves close back again, okay? And then during late diastole, that's when you have passive ventricular filling into those ventricles. So pretty straightforward stuff. So let's go into the cycle in a little bit more detail again. So atrial systole. So atrial systole, that means SA node is firing because your SA node is the cardiac pacemaker, right? That's your natural pacemaker of the heart. That's when you also see the P wave on the EKG or ECG, if you're American versus German. So on your ECG, you're going to see the P wave. That's when the atria now are depolarized. Atria are now going to contract. So that's where you have atrial systole. And then when the ventricles become filled with blood after atrial systole, that's going to be your end diastolic volume. Okay, so your end diastolic volume is when your ventricles are completely filled with blood. I'm going to tell you why that's important in a moment, because we're going to learn how to calculate stroke volume as well as cardiac output. So your end diastolic volume is going to be a pretty important number for you to get. And then you have that isovolumetric contraction. Iso, meaning same, volumetric, regarding the volume of blood in those chambers. It's contracting, but the change of the volume, the volume is not changing. It's remaining the same. You're going to have, during that phase, you're going to have atrial repolarization, and then you have atrial relaxation. Then what's going to happen is your ventricles begin to depolarize, and when you get depolarization of the ventricles, that's when you begin to get that contraction. That's also when you see that QRS complex, that big spike on the ECG. The QRS complex, remember, is going to correspond with both ventricular contraction, ventricular depolarization, as well as atrial repolarization. At this point, the mitral valve and the tricuspid valve close. Okay, that's going to be the first heart sound. That's S1. When you hear lub-dub, that lub is going to be both of those atrial ventricular valves closing at the same time. At this point, you do not have ejection of blood. Blood is still going to remain within the ventricles. You do see ejection of blood once you get into the second phase of ventricular contraction. So that's phase 2. At that point, now it's no longer isovolumetric. Now you actually get change in the volume, right? Now you're actually beginning to pump all the blood out of those ventricles, both into the pulmonary trunk as well as the aorta. This is when the semilunar valves open, and this is where you get the actual stroke volume. Okay, so that's the amount of blood that's actually being ejected per heart contraction. That's the stroke volume. That happens in one single beat. On average, it's like anywhere between like 50 to 70 milliliters of blood. That's the average. That can change if you're like exercising. That can also change if you have any sort of like cardiac damage from either a cardiac myopathy, or maybe you have like dilated cardiomyopathy. Those are all going to be things that can affect your stroke volume. We're going to talk about what that means a little bit later. Now, speaking of stroke volume, remember your end diastolic volume. That's end diastole is when your ventricles are completely filled with blood. Okay, that's going to be your end diastolic volume. Your end systolic volume is after the ventricles contract completely. That's at the end of systole. That's the amount of blood that remains within the heart. Now, in order for you to calculate your stroke volume, you subtract the end systolic volume from the end diastolic volume. So this end diastolic volume is going to be the bigger number. And then when you fully contract the ventricles, you wind up with the end systolic volume. The difference between those two is going to be your full-on stroke volume. I'll show you some calculations about that later on, so don't worry about that just yet. Just keep those in mind for now. Then you're going to have isovolumetric relaxation. That's when the ventricles begin to relax. This is when you have repolarization of the ventricles. Okay? So remember on the ECG, when you look at the T wave is going to correspond to ventricular repolarization. All right? Then there's going to be something I'm going to show you later on. We have this like giant chart, and you're going to be able to see a dicrotic notch. Actually, let me go ahead and fast forward so I can show that to you right now. So this right here, this is the dicrotic notch. That dicrotic notch is going to be involving rebound of pressure as the aortic valves close. So over here you have the aortic valves opening up, And as they close, then you have this rebound. That rebound is going to be due to the elasticity of the aorta, as well as the pressure that builds up as you have closing of that valve. So that's that dicrotic notch. That's basically when you have the end of systolic contraction. So let's go back to that. We're going to talk about that whole entire chart in a second, because you're definitely going to have to be responsible for that on your exam. So you need to know each of those different components on that chart. When the aortic valve closes, that's going to be that second heart sound. That's going to be S2. That's going to be the dub of the lub dub. Okay. Then moving on, and then you get into diastole. Bless you. When you get into ventricular diastole, that's when the ventricles just basically relax and all the blood just basically fills in passively. It's going to be a very passive type of reaction. So this is the Wiggers diagram. It's named after Carl J. Wiggers, which is a very unfortunate name. Anyways, so up here on the top, you have the ECG. So keep mind of all these different landmarks, right? So you have the P wave, that's atrial depolarization, the PR interval, that's going to be atrial contraction, QRS complex, ventricle repolarization, ST segment, ventricular contraction. Then the T wave is going to be ventricular repolarization. Over here in the middle, that's going to be the pressure. And so here's the pressure within your aorta versus pressure within the left atrium versus pressure within the left ventricle. So we're only really looking at the left side of the heart on this diagram. Okay, the left side of the heart is arguably one of the more important parts because it's pumping blood into your systemic circulation. So let's look at the aorta. So if you put a little pressure gauge inside the aorta, that's what's happening over here. First, you have the atrium are beginning to contract. So atria contracts, brings blood into the ventricles, and over here at the QRS complex, that's when the ventricles contract. Once the ventricles contract, then the aortic valve opens. All of a sudden, blood comes rushing into the aorta, and that's where you see the increase in pressure right over here. Right? So that's going to be a little stage 5 right there. That's going to be systolic contraction of the ventricles, bringing blood into the aorta. Once systolic contraction basically ends, then you have closing of the aorta. Now remember the lub dub, that's going to be the dub. Okay? Lub is going to be as the ventricle begins to contract. The dub is going to be when the aorta closes. As the aortic valve closes, that's going to be that dicrotic notch right here. That's when blood stops leaving the ventricle into the aorta at that point. Then you have in the ventricle now is going to begin relaxing, right? So this is going to be ventricular diastole. And then once the ventricles completely relax, that's when the valve actually opens. This valve right here, that's, what's the name of the valve that's in the ventricle? You guys remember? It says AV valve, but I want you guys to remember which valve that is. Left ventricle. Yeah, the bicuspid or mitral valve. So this is when the mitral valve opens. And then when the mitral valve opens, that's when you get blood entering into the left ventricle from the atrium, and that's going to be passive filling into the ventricles. And then in terms of volume, so this is going to be your stroke volume. This is end systolic volume. That's when all the blood got pumped out of the ventricles. And then up here, that's going to be end diastolic volume. That's when you have the maximum amount of blood within the ventricle before the ventricles contract. So make sure you know each of these little landmarks over here, how they correspond to the QRS complex, at which point the aortic valve actually opens, at which point the mitral valve or the bicuspid valve actually opens. Okay, know every single one of these points because you're going to be responsible for that on your test. And then this chart over here shows you how the heart sounds correspond with each of those different valves opening and closing, or closing rather. So that lub, that's going to be your S1, right? That's going to be the very first heart sound. Lub means your ventricles are entering into the first phase of ventricular contraction. That's the isometric contraction. Okay, so first thing that closes are those atrioventricular valves. That's going to be the first heart sound. And then all of a sudden the aorta opens, and that's when blood enters into the aorta, right? The aortic valve opens. As soon as the aortic valve closes, that's when you get that second heart sound. There's also some other heart sounds as well. Generally speaking, if you hear a third and fourth heart sound and it's really pronounced, that means that there's some underlying pathology taking place in the cardiovascular system. We're not going to talk about S3 and S4 sounds. You guys are not responsible for that yet. Once you guys get into pathology, pathophysiology, that's when you guys need to learn the different conditions that can result in a S3 and an S4 hard sound. And here's my little mnemonic that helps me remember exactly where to auscultate the different valves on the heart, on the patient's chest. So let's go over it again. So all physicians take money. So that's going to be aortic valve, pulmonic valve, tricuspid, and mitral. The very first one is going to be this guy over here. That's going to be on the right peristernal. So here's the sternum. If it's peristernal, it means it's adjacent to the sternum. And the second intercostal space. So here's your first rib, second rib, third rib. That's your first intercostal space. That's your second intercostal space. So it's between ribs 2 and 3. That's going to be corresponding to the aortic valve. Then you move your stethoscope over to the left side of the patient's chest. So that's going to be left peristernal space between the second and third, again, intercostal space. Second intercostal space between ribs 2 and 3. Then for the third sound, so tricuspid, you're going to move your stethoscope all the way down. I don't like the way they drew this. It's actually supposed to be on the fourth intercostal space. They kind of put it directly over the fourth costal cartilage. I don't really like that. They should have moved this a little bit higher up. But regardless, you go to the left peristernal area in the fourth intercostal space. That's where you listen to the tricuspid valve. And then finally, when you want to listen to the mitral valve, you go mid-clavicular line. Here's your clavicle. You go directly down the middle, and you 1, 2, 3, 4, 5 intercostal space. Your fifth intercostal space is where you hear the mitral valve. So just keep that in mind later on when you guys get into your clinicals, when you start auscultating heart sounds. Those are the different regions you want to listen to. If you want to get really crazy and you want to listen to the patient's apical heartbeat, which you sometimes you want to do if you're listening for a patient that might have like cardiomegaly, they might have an enlarged heart. This area right here to listen to the mitral valve might be moved a little bit further down if they have a big heart for cardiomyopathy. To be able to really figure out what that sounds like, what you do is you have the patient lay on their side, on their left side, and then you turn your stethoscope, assuming you have a really good one, because there's some stethoscopes that only have the diaphragm. But if you have the one that has a bell on it, so you just flip it to the bell, and then you're going to put your stethoscope right in that, go a little bit lateral to that mid-clavicular line, and so you try to listen to that apical heart sound. And so if the patient has like cardiomyopathy, like a cardiomegaly, you might be able to hear a pretty pronounced apical heart sound. All right, so here's kind of that summary of the cardiac cycle. You have quiescence, that's going to be kind of passive filling of the ventricles. You have the ventricular filling, that's when the atria actually contracts, bringing blood from the atria into the ventricles. Isometric contraction versus ventricular ejection, and then at the end you have isovolumetric relaxation. And just know that the lub corresponds to the atrioventricular valves. Dub is going to correspond to the semilunar valves. So here's another summary of all that. Actually, let's talk about pressures. This is going to be more in terms of pressure. So as the pressure builds up in the atria, if the atria has more pressure than the ventricles, that's when you have atrioventricular valves opening up. That's when you get filling of the ventricles. If the ventricular pressure is greater than the atrial pressure, then those AV valves close, right? Because pressure builds back, then the mitral and the tricuspid are going to close up. You're going to have no more blood going backwards unless you have a mitral valve prolapse, for instance. If the ventricular pressure is more than the aortic valve, then the semilunar valves open up. That's when you have blood finally getting into the aorta. Once the ventricles relax, then you're going to have increased pressure within the aorta. Then you're going to have closing of those semilunar valves, which corresponds to the dub in lub dub. So let's watch a little video on this. This will work. Short video.
Cardiac output is the amount of blood pumped by each ventricle in 1 minute. It is the product of stroke volume, the amount of blood pumped in one heartbeat, and heart rate, the number of beats in 1 minute. An increase in either stroke volume or heart rate results in increased cardiac output, and vice versa. For example, during physical exercises, the heart beats faster to put out more blood in response to higher demand of the body. It is noteworthy that the ventricles do not eject all the blood they contain in one beat. In a typical example, a ventricle is filled with about 100 milliliters of blood at the end of its load, but only 60 milliliters ejected during contraction. This corresponds to an ejection fraction of 60%. The 100 milliliters is the end diastolic volume, or EDV. 40 milliliters that remains in the ventricle after contraction is the end systolic volume, or ESV. The stroke volume equals EDV minus ESV and is dependent on three factors: contractility, preload, and afterload. Contractility refers to the force of the contraction of the heart muscle. The more forceful the contraction, the more blood it ejects. Preload is related to the end diastolic volume. Preload, by definition, is the degree of stretch of cardiac myocytes at the end of ventricular filling. But since this parameter is not readily measurable in patients, EDV is used instead. This is because the stretch level of the wall of the ventricle increases as it's filled with more and more blood. Just like a balloon, the more air it contains, the more stretched it is. According to the Frank-Starling mechanism, the greater the stretch, the greater the force of contraction. In a balloon analogy, the more inflated the balloon, the more forceful it releases air when deflated. Afterload, on the other hand, is the resistance that the ventricle must overcome to eject blood. Afterload includes two major components: vascular pressure. The pressure in the left ventricle must be greater than the systemic pressure for the aortic valve to open. Similarly, the pressure in the right ventricle must exceed pulmonary pressure to open the pulmonary valve. In hypertension, for example, higher vascular pressures make it more difficult for the valves to open, resulting in a reduced amount of ejected blood. Damage to the valves, such as stenosis, also presents higher resistance and leads to lower blood output.
All right. Pretty good summary. The one thing that I would add to what she said, and we're going to talk about that with regard to the Frank-Starling law. If the heart is dilated, like beyond what it's supposed to be, so a great example of that would be dilated cardiomyopathy. Oftentimes, some drugs can cause that, but it's commonly caused by long-standing alcoholism. If somebody drinks too much, especially like beer, whatever, you're subjecting the body to a lot of fluids, and over a long period of time, just because of that fluid overload, you start causing stretch to the heart, and so that can result in, over time, dilated cardiomyopathy. Like one of the worst ejection fractions I ever saw was in a patient with dilated cardiomyopathy. He had like an ejection fraction of about like 20, I think it was like 24%. It was really, really low. If your heart is stretched out way too much, you're not going to get a really good contraction, okay? Because of actin and myosin filaments are really not going to be able to like get a good grip on each other. And so if it's dilated too much, you're going to get a very weak contraction, resulting in reduced ejection fraction. So she was talking about how you stretch it out by like a balloon. Decent analogy, but only up to a certain extent. So in terms of end diastolic volume, that is what you have as the heart is completely filled. Okay. As you contract the ventricles at the very end, that's going to be end systolic volume. To calculate your stroke volume, you take end diastolic volume, subtract end systolic volume, and then cardiac output. Cardiac output is going to be the amount of blood that the heart pumps within 1 minute. And so that's going to be directly proportional to the heart rate. So if your heart rate is increased, right, if you're like exercising, you're running, your stroke volume, your cardiac output is going to be increased, because that elevated heart rate plus your stroke volume, or multiplied by your stroke volume, is going to increase your overall cardiac output. And then when you do your ejection fraction, that's going to be your stroke volume in one beat divided by the end diastolic volume. That's going to be the amount of blood that's actually pumped out within one heartbeat, okay? One systolic contraction. So this is what the equation looks like. Ejection fraction, that's going to be stroke volume divided by end diastolic volume over here. To calculate for stroke volume, you should know this equation, end diastolic volume minus end systolic volume. So here are a couple examples of questions that you might see on your exam. If you had an end systolic volume of 80, okay, so that's going to be after your heart contracted. End diastolic volume of 130, that's the total amount of blood that was in your ventricle before contracting. 50 is going to be your stroke volume. And to calculate ejection fraction, you divide 50 divided by end diastolic volume. And that's going to be about 38%. This patient right here is not doing too well at 38%. That's a pretty low ejection fraction. End systolic volume of 50, end diastolic 30. You're going to have a stroke volume of 80. 80 divided by 130, 61%. That patient's normal. That's within normal limits. And in the when you guys go into your clinicals, and if you work in like cardiology, the way that they do this, they usually use an echocardiogram. When they do the echocardiogram, they can see the total amount of blood filled in the left ventricle, then they see the total amount of blood that was actually pumped out, and then that's how they're able to calculate this. They don't have to go in with probes. They don't have to go in with like weird devices to measure anything. This can be done just using a simple echocardiogram. And I was going to show you a video of that, but kind of unnecessary for you guys right now. Just understand the underlying concept. Echocardiograms, kind of hard to read unless you have a well-trained eye. All right, so let's talk about the things that affect stroke volume. So let's talk about preload versus afterload. So preload is going to be the amount of blood that comes to your heart from the venous system. Okay, so if you have a high preload, if your venous system is bringing lots of blood back to your heart, that's going to increase the preload. And that's going to approximately be associated with the end diastolic volume. Then contractility, that's going to be how hard your heart is pumping. Certain drugs can affect contractility. Certain drugs can, like for instance, epinephrine, norepinephrine, can increase the contractility of your heart. Some can slow down or reduce the contractility of your heart. We'll talk about some of those drugs in a second. Afterload, think about everything that's downstream from the heart. If you have increased total peripheral resistance, for example, you have vasoconstriction, right? If you have vasoconstriction, you're going to increase the total peripheral resistance, and that's also going to increase your afterload. So in other words, you have a lot more resistance to your heart. Your heart is going to have a really hard time pumping against all that pressure. So that's going to affect your stroke volume as well. So here are a couple examples of what you might see on your test. If you had increased preload, that means you now have increased end diastolic volume, which means you also have increased stroke volume. If you have increased contractility, that means your heart is pumping very efficiently. You might be like out there jogging or something, doing some strenuous exercise. You're going to have reduced end systolic volume because most of the blood got pumped out of the ventricles. That's also going to increase your stroke volume. If you increase your afterload, say for instance, you take a certain drug that causes vasoconstriction, then you're going to cause increased end systolic volume. That means not enough blood was able to get pumped out of the heart because you have a lot of pressure that you're trying to pump up against. That's going to reduce your stroke volume. Okay. Some of the things that might affect preload, as this chart shows, you might have hemorrhage, you might have hypovolemia, or you might be dehydrated. That's one thing. You might have regurgitation. So you might have damage to your mitral valve, you might have damage to your tricuspid valve, causing prolapse. As your ventricles contract, blood now is starting to go backwards, right? If you have a prolapsed heart valve. Or heart failure. There's going to be right-sided heart failure, and there's going to be left-sided heart failure. If you have any sort of heart failure, depending on what side, you're going to have all sorts of different symptoms. But in general, heart failure is going to result in decreased preload. If you increase your afterload, that means everything downstream. If you have increased total peripheral resistance, if you have high blood pressure, hypertension, vasoconstriction, those things are going to increase your afterload, and those are going to decrease your overall stroke volume. So This is kind of a simple breakdown: increased preload, increased end diastolic volume, increased stroke volume. As that video was talking about earlier, the more stretch you have in your myocardium, that can increase the strength of the contractility, but up to a certain point, right? If you stretch too much, your actin and myosin are not going to be able to cross-link effectively, and you're not going to get a decent contraction from that. So things like exercise, for instance, exercise as you're jogging, you're going to increase the amount of blood coming back to your heart, increases end diastolic volume. That increased stretch is going to increase your preload. Then you're going to have increased contractility, pumping a lot more blood out from your ventricles than you otherwise would. Now, this is that Frank Sterling law chart that I was referring to earlier. There's an ideal point. Over here, you don't really have anything going on in terms of end diastolic volume, so your stroke volume is not going to be anything. You're not really going to have much in terms of stroke volume. Once you get to a point where you have that optimal stretch and you have like optimal gripping between the actin and myosin and the sarcomeres, then you're going to have a really good contraction, right? You're going to have a optimal stroke volume. If you have dilated cardiomyopathy, if your heart's too big, then you're not going to get proper connection in the sarcomeres, okay? And then because of that, you're going to have a reduced amount of ejection fraction. You're going to have a reduced stroke volume because it's no longer ideal. So these are some of the drugs that can have different effects on your contractility. Now, these are going to be referred to as ionotropic agents. You can also think of some of these as being like chronotropic. Chronotropic pertains specifically to timing. So you can have certain types of drugs that slow your heart down. You can also have certain drugs that just make your heart pump harder or pump weaker, depending on what your ultimate goal is. But let's talk about ionotropic compounds. Ionotropic compounds basically can either increase contractility or reduce contractility. If it increases contractility, positive. That's a positive ionotropic compound. And the opposite is going to be a negative ionotropic compound. Positive, we already talked about some of these: epinephrine, norepinephrine. So that's going to be sympathetic response. So if you're getting chased by a lion and all of a sudden your adrenal medulla starts cranking out a bunch of norepinephrine, epinephrine, that's going to increase your heart contractility. It's also going to increase your heart rate, and it's going to have several effects in your venous system as well. Dopamine can also do that. Dopamine can increase contractility. That's why, for instance, like drugs that increase dopamine in your body, like cocaine, for instance, cocaine increases heart contractility. Heart rate goes up, contractility also goes up. Negative ionotropic agents, beta blockers, very commonly used for patients that have hypertension. Maybe they've had previous MI. They'll go on beta blockers, and beta blockers basically help to reduce total blood pressure because they slow the heart down. They also reduce contractility. Metoprolol, labetalol, atenolol, there's a ton of different types of beta blockers, bless you. Some of these are actually not just used for cardiovascular, some of these are actually used for psychiatry too. What do you think would happen if you take a beta blocker in terms of psychiatry? Slows your heart rate down, which might do what? Calm you down. Yeah, so you can actually use like metoprolol as a anxiolytic. It can reduce anxiety. It's commonly used for people who have performance anxiety, people that have a hard time getting in front of people, talking to people in public. I had one of my supervisors when I was doing psychiatry. They were going to do this really important presentation. And all of their colleagues, they're all residents, so they had to like do well to perform in their program. He gets nervous a lot, so they actually slipped metoprolol in his drink. And so he gave this like really great presentation. He was totally relaxed. They told him afterwards what they did. These are pretty benign drugs. They don't really have serious effects on you. I personally wouldn't do that to anybody. It's like, it seems a little unethical, but they were trying to help a brother out, you know? So he did well, so. You can also use calcium channel blockers. Remember, calcium has a very significant role in heart contractility. So amlodipine is a very commonly used calcium channel blocker, and other antiarrhythmics as well. So contractility versus stroke volume and end systolic volume. So let's see. If you have reduced contractility, if the heart's not beating well enough, okay, that's going to increase your end systolic volume. That means you're not pumping out enough blood, you're decreasing your stroke volume. Now here's the question. If your ventricles aren't contracting properly, where does the blood go? If it's not pumping out through the pulmonic trunk or through the aorta. What happens if you have right-sided heart failure? You're not getting enough blood to your lungs, that's for sure. What else is happening with right-sided heart failure? So think about it. Your right side, you're getting blood from the rest of your body, right? If you're not able to get the blood from your body to your lungs, what's going to happen to the blood in the rest of your body? Well, you're not going to have proper oxygenation, but more importantly, it's going to start pooling in the rest of your body. You're going to start getting edema. You might start getting ascites, right? You might start getting swelling because you're not able to get all that blood pumped correctly. So if you had right-sided heart failure, that's going to cause systemic edema. So you might get myxedema, you might get ascites. I'm going to show you some pictures of what that looks like. So that would be right-sided heart failure. What about left-sided heart failure? It's more involving the lungs. So what happens with left-sided heart failure? Huh? Yeah, did you say pulmonary edema? Exactly. So if you can't pump the blood out of your left ventricle, that blood is going to start backing up into your lungs. And if you start getting blood backing up in your lungs, you start getting pulmonary edema. So you start getting fluid buildup in your lungs. And so they call that congestive heart failure. Okay, so if you have congestive heart failure, you're getting edema. Edematous results because of the inability to contract properly. So you might get congestion in the rest of your body. So that would result in edema. And if you get left-sided heart failure, that's called left-sided congestive heart failure. And that causes fluid buildup in the lungs. So we refer to that as CHF, congestive heart failure, resulting in pulmonary edema. You're not able to get the blood out of your left ventricle, and so blood just starts basically pooling up in the reverse fashion. Versus right-sided heart failure, right-sided congestive heart failure, you're going to get all sorts of systemic type of edema. So you're going to get pitting edema in your lower extremities. You might start getting ascites. You guys remember what ascites is? We talked about that when we talked about liver failure, cirrhosis. Ascites is where does fluid build up when you have ascites? The peritoneum, exactly. So you have fluid buildup in your peritoneal cavity. You have to usually give the patient a peritoneal centesis. You have to you have to aspirate the fluids out of their peritoneal cavity. So congestive heart failure. Think about different types of cardiomyopathies, including dilated cardiomyopathy. That's why it's not always good to have a big heart. If you have dilated cardiomyopathy, you're not going to have the ability to properly contract. And that goes down to the cellular level, all the way down to the sarcomeres. These are some radiographs of what it looks like. This over here is pre-treatment. That's post-treatment. Pre-treatment, you see all that fluid buildup throughout the lungs. After you treat that patient, you can give them things like diuretics, right? So they can remove more fluids. You can give them certain types of drugs like ACE inhibitors, angiotensin receptor blockers, things like that. Basically, those can help to relax blood vessels. Those are some of the ways you can treat congestive heart failure. And this is pitting edema. I included this over here because there's various levels of pitting edema. There's some just mild edema that just could be just a little bit mild, like fluid overload, things like that. And then it gets all the way up to level 4 pitting edema. Pitting edema, the way you measure it, you poke the person's leg. You press down as hard as you can. Well, not as hard as you can. You press down to see if you can get a little indentation in their skin. And then you sit there and wait. If it's for more than 2 minutes, that's going to be the most severe form of pitting edema. And that's going to generally indicate that the patient has something going on with the right side of their heart. They have some form of right-sided heart failure. Some of the treatments you can use, you can try to reduce sodium intake. That's going to be one approach. You can use diuretics. Okay, so Lasix, for instance, would help to remove some of the extra fluid. Compression stockings. That's going to be a common treatment for a lot of patients that have edema. You can also use compression stockings for people that have like postural hypotension. When they get up, they faint because all the blood kind of pools in their legs. So they can use compression socks for that as well. But for pitting edema, generally speaking, you want to give them compression socks to reduce the amount of fluid buildup. Now, in terms of afterload, recall that has to do with everything downstream, right? Everything downstream that you're trying to pump towards, okay? So if you have increased pressure downstream, so if you have like increased mean arterial pressure, for instance, then you're going to have increased afterload. That's going to reduce your overall stroke volume because you're not able to pump the blood up against all that pressure. So anytime you increase resistance, that's increased afterload. Things like arteriosclerosis does that. Things like lung disease can do that too. So like pulmonary fibrosis, that means that you have like fibrous lungs that aren't able to fill up properly. If you have pulmonary fibrosis, generally speaking, over time that can result in right-sided heart failure because the heart is having a hard time pumping up against all that pressure. And then if you have left-sided heart failure, this especially is going to result in hypertrophic myocardium. So hypertrophy, meaning that the heart is trying to pump so hard against all that pressure that over time the heart muscles, just like if you work out, you start getting bulkier, right? The heart does the exact same thing. The harder the heart has to work, the more thick it gets, the more you start getting hypertrophic cardiomyopathy. So let's figure out what these different, what preload will do to stroke volume. What happens if you increase preload? You have increased stroke volume, increased preload, increased stroke volume, right? What if you have increased afterload? Decreased stroke volume, right? So if you have too much resistance in your afterload, then you're going to decrease your stroke volume. What about decreased preload? Hold on a second. The exact same thing. I did that twice. Whoops, my bad. So same thing. We did it twice, right? Decreased preload would cause. Oh, never mind. The arrows are changed. What does decreased preload do? Decrease or increase stroke volume? Decrease. Decrease afterload. Increase stroke volume. Excellent. All right, so let's talk about cardiac output a little bit here. Just recall, just remember the equation. Cardiac output is going to be the amount of blood that the heart beats out in 1 minute. Okay, so it's going to be heart rate, so your pulse rate, multiplied by your stroke volume. So there's a couple things that do affect cardiac output, which is kind of interesting. In your joints, if you're like doing exercise and doing a lot of movement, you have proprioceptors. Proprioception is the ability for your body kind of to recognize where your appendages are in space. So proprioceptors are also going to affect your cardiac, your heart rate. So if you're like exercising, if you're jogging or running, your proprioceptors are basically going to trigger your heart to start pumping faster. If you have increased venous return, now if you're exercising, you got contractility. We're going to talk about why that's important when we get into vessels. But when your muscles are contracting, they're helping to push blood through your venous system. I guess before we get into that, why does blood not just like remain stagnant in your veins? Because let's think about it this way. In your arteries, you have much higher pressure than you do in your venous system. Your venous system overall has reduced blood pressure. Now, in terms of blood movement, why does blood not pool in your venous system? What's in your veins that helps blood return back to your heart? Do you guys know? So there's actually unidirectional valves. There's valves throughout your venous system that help to move blood back against gravity back towards your heart. As you exercise, like for instance, if you flex your calf muscles, it's going to push blood up, and then that blood is going to get trapped on the other side of the valve. And then once you flex your muscles again, the blood keeps on moving. And so whenever you move, whenever you exercise, when you walk, if you flex your muscles, that helps to move blood from your venous system back towards your heart. So muscle activity is going to help to increase venous return, and that's going to help to increase stroke volume. All right. So we ended a little bit earlier than I thought we would. So let's go ahead and do the third quizzes for chapter 19. So I'm going to use this for our participation points today. We're going to get into the venous system a little bit, but we're not going to do a quizzes on that just yet, only for next week. So let me go ahead and start this. All right, so go ahead and log in. All right, one more. All right, let's go ahead and begin. If I miscounted and you didn't log in, just like always, give your name to Saudia so we can update you. So we didn't really talk about this in lecture, but it's pretty straightforward if you just look at the term chemoreceptors. Chemo meaning that they're reacting to different chemical levels within the blood. Blood pressure is not chemical. Blood pressure is just the pressure in your arteries, as well as in your veins too. But decreased O2, yes, the heart is going to respond to that, right? So if you have decreased O2, you're going to have to try to increase the amount of oxygen getting pumped out into your body. And so that's going to affect heart contractility. Increased carbon dioxide levels. You have way too much carbon dioxide in your body. That means you need to try to expel that carbon dioxide through your respiratory system. That's going to affect your heart. And decreased pH levels. Generally speaking, there's a couple different types of acidosis, but let's take, for instance, respiratory acidosis. You have an accumulation of carbon dioxide. You want to breathe that out, and so your heart's going to pump more to try to get to try to expel as much carbon dioxide as possible. That's kind of like the overview of those different effects. Just know that blood pressure is not that's not going to be associated with chemoreceptor. What kind of receptors would blood pressure affect? Baroreceptors. Awesome. Baroreceptors would be blood pressure. All right, that's quite a stretch, or quite a spread. Preload, what's preload? What's preload? I'm gonna pick on someone. Does anyone want to volunteer? Yeah, it's the amount of blood coming to the heart from the venous system. So that's preload. What is, well, not many people answered afterload. That's going to be basically what you're trying to pump up against, right? That's the afterload. Stroke volume. Stroke volume. Is that within a minute or is that just one beat? one beat, right? So stroke volume is just one pump. That's the amount of blood that's able to get pumped out. We usually measure the left ventricle, so it's the amount of blood that's able to be pumped out of the left ventricle in one pump. Cardiac output, that's going to be what? How do you calculate cardiac output? What's the equation? Heart rate times stroke volume. So that's going to be cardiac output. So it's within 1 minute. So it's going to be milliliters per minute. Cool. So make sure you guys know those equations. You guys are going to need those for your test. So what valves are going to be found in the left side of your heart? The aortic valve and the mitral valve. Awesome. The bicuspid, also mitral, but the pulmonary valve is going to be associated with the right side of the heart. So most of you guys got that correct, which is awesome. This is a fun question. I hope most of you guys got it right. Good, most of you guys got it right. That's awesome. Hypothyroidism would decrease heart rate. Acetylcholine. Does acetylcholine have an effect on the heart? Does it? Yes, no? You don't think so? It does. There's muscarinic receptors on the heart. And so acetylcholine does have an effect on the heart. It will reduce contractility. So it'd be kind of like a parasympathetic type of response. Vagus nerve stimulation. Does vagus nerve stimulation have an effect on the heart? Yeah, so it would be the same thing. It would be like a parasympathetic type of reaction. Vagus nerve stimulation would actually reduce heart contractility. So norepinephrine would be the correct answer. All right, end diastolic volume. End diastolic volume would affect your cardiac output. Why? What's the equation? What's the equation for stroke volume? EDS minus ESV, right? So that's going to be stroke volume. And then how do you calculate cardiac output? Heart rate times stroke volume. Good. This one might have been a little tricky for some of you guys. If so, we'll go back to it real quick and I'll show you why that might have been counterintuitive. All right, good. I knew that this was going to trick you guys. So the SA node, That's going to be the pacemaker within the heart. But the cardiac center is actually in the brainstem. It's going to be found in the medulla oblongata. So let's actually go back to that. I did foresee that you guys would get confused by that, so let me actually do this. Let's go back to it. There it is. This slide right here. So this is going to be the parasympathetic and sympathetic effects that the brainstem will have on the heart. And these regions right here, those are those regions in the brain that will either increase or decrease your heart rate. So you have acceleratory and you have inhibitory centers. That's going to be found within the medulla oblongata. Okay. Now, that is going to be a little bit different than the SA node. The SA node is just going to be the internal pacemaker for the heart. But the heart rate can be changed depending on whether or not you have parasympathetic versus sympathetic activation. Okay, so just make sure you know that if you see like the cardiac center, right? Cardiac center is specifically referring to the medulla oblongata. Does that make sense, guys? All right. A little bit of a trick question, but. Cool, good. So you guys remember negative inotropic is going to be contractility. Chronotropic would be reduced heart rate. It would just slow the heart down. Chrono means time, right? So it would reduce the amount of time for the heart to beat. Okay, so it would just slow the heart rate down. But inotropic would be the actual strength of the contraction. Okay, that's contractility. All right, one more, and then we'll get into chapter 20. All right, awesome. So Purkinje fibers, you guys got that right. I'm glad to see that. Awesome. So bundle of His, that's going to be where you have, so it goes AV node, bundle of His, bifurcates into the right and left bundle branches, which turn into the Purkinje fibers, and those Purkinje fibers directly stimulate those cardiac myocytes. So good job on that. Let's get into a little bit of chapter 20. All right, so I included this image over here because this thing right here is a silent killer. Oftentimes when a patient has an aortic aneurysm, they have no idea, usually until it's too late. One of the biggest concerns about an aortic aneurysm is a condition called an aortic dissection. Have you guys ever heard of that before? An aortic dissection, there's two types. You don't need to know about them, but the one type will kill you like within a minute. So you basically, it blocks the ability for your blood to get pumped out your body, and you'll get like a crushing substernal chest pain, and then you'll pass out and basically die. This person was lucky. They had a hemodynamically stable aortic rupture. So the aorta ruptured, but they were still able to survive. This is what the aorta is supposed to look like. Okay, once it starts getting dilated, I believe it's 5 centimeters, but I might be wrong about that. But if it starts getting to be about 5 centimeters in width, that's when you would consider that an aortic aneurysm. And generally speaking, you really want to get that patient to surgery. They'll usually put in like a stent in there just to stabilize the aorta. Because if you get an aortic dissection, that's generally speaking fatal, and very rapidly so. It actually killed one of the singers from one of my favorite bands, the Cramps. That's how he died. So let's move on and talk about the vascular system. So the vascular system is going to be a closed loop system, okay? Meaning that you don't have anything coming in, you don't have anything coming out. So it's going to be flow between the heart as well as all the organs. Arterioles are going to be one of the most important features in the vascular system that help to control the actual amount of blood that gets funneled off to different organs. So, for instance, if you ate a really heavy meal and now you're in that rest and digest phase, arterioles within your mesenteric system are going to start to dilate, so you get more blood going to that area so that you can start digesting and absorbing nutrients from that meal. Then the arterioles in the other parts of your body that aren't necessary during that time might start to vasoconstrict. Okay? And in terms of exchange of materials, that's going to be within the capillary beds. The capillary beds is where you get exchange of gases like oxygen as well as carbon dioxide. And that's where you get other things like nitrogenous wastes from amino acid breakdown. You get other types of waste built up, and that's where they get transported through the vascular system. Now, in order of sequence, from your heart, you get blood pumping into your arteries, right? Arteries are going to be moving away from the heart. The arteries, as they start getting smaller and smaller, soon become arterioles, and then the arterioles, as they become really tiny and thin, that's when they become capillaries, and they're going to become capillary beds. That's where you get the exchange of nutrients as well as gases in your tissues. Once blood starts getting into the venous system, they first enter into the venules, and then veins, and then eventually getting back to your heart, that's going to be through the vena cava. And I skipped the aorta. So just note aorta, arteries, arterioles, capillaries, venules, veins, and then vena cava. Oh yeah, and then speaking of which, in terms of cross-section, that means the total amount of surface area. So if you were to look at the total surface area of the capillary beds are going to be the most area that you see. That's why you want to maximize surface area so you can maximize the amount of materials that can be transported in and out of the circulatory system. In terms of velocity, aorta is going to be the fastest portion, right? That's where blood is first getting into the arterial system. And then that's going to be the highest speed. As you start getting into the capillary beds, the speed of blood is going to be really slow. That's going to help to maximize the amount of time that where you can get diffusion of gases as well as transport of those nutrients. And then the velocity starts to increase a little bit once you get into the venous system, but because the venous system is basically further away from the heart, the overall blood pressure as well as the speed of the blood is going to be much slower just because of distance. So let's talk about some of the differences in those different vessels. So this is a really good chart from your textbook. It basically breaks down all the different vessels and some of the major components of each of those vessels. So generally speaking, you're going to have three major layers of your vessels. You have your tunica externa, tunica media, and tunica interna. In the large vessels, you're going to have those similar layers. You have tunica intima. You also have the tunica intima in veins. Tunica media, you also have tunica media in the vein. You have tunica externa. You also have tunica externa in the vein. Now, the major difference, as you can see from this image here, is that in arteries, the tunica media, which is made up of smooth muscle, are going to be much thicker than you see in veins. The veins are going to have tunica media, but those smooth muscle layers are going to be much, much thinner. And then moving down, once you start getting into the arterioles, you start losing the tunica externa. Once you start getting those narrower little passageways, you're going to see the tunica media is still present. And the tunica media, that's what constricts or dilates depending on where you want to siphon blood towards, right? If you want blood to go to your GI when you ate a big meal, or if you want blood to go to different organs, depending on what the requirements are, those smooth muscles are going to be really important in that effect. And then once you get down to the capillary beds, all you have left are endothelial cells as well as the basement membrane. And in those capillary beds, they're really thin, so you can get easy diffusion of different substances, whether it's gases or other sort of like nutrients or waste products. Then when you start getting into venules, it starts getting a little bit thicker. You get that tunica externa again, okay? And then once you get into the medium-sized veins to the large-sized veins, that's when you start seeing the tunica intima, tunica media, as well as the tunica externa. Okay, so you have all those three layers all over again. So here's another breakdown of what that looks like. So this would be all arterial system. So these would be large arteries. Take, for instance, the aorta. The aorta is going to have the outer layer, aka the tunica externa. Then you start getting into the middle layer, tunica media. That's going to be smooth muscles. And that's going to be a really thick layer of smooth muscles. And then you get basement membrane and then the endothelium. And this whole entire region right here is going to be the tunica intima. As you get into the arterioles, you still have those three layers. You have the tunica externa, tunica media, smooth muscle, and the tunica intima. But then when you get to the capillary beds, all you have left is just the basement membrane as well as the endothelial layer. What else do you need to know here? Oh, and then here, remember we talked about those valves that you find in your venous system? These are what the valves look like. They're going to be unidirectional. They're going to be pointing up because as the blood gets pumped up from like your lower extremities, for instance, the blood doesn't go back down. It stays. It gets trapped in that valve. And by the way, those valves can actually prolapse and become defective over time. We'll talk about some of those conditions in a second here. If those become prolapse, that's when you start getting varicosities. If you start getting varicose veins, those like big bulging veins that kind of look unsightly, those are going to be usually due to damage to these valves. So you do have pooling in those the venous system of your lower extremities. So in terms of blood transportation, this organ right here, the brain, that's going to be our most important organ. It's always going to have demand for oxygen. That's why if a patient has like ventricular fibrillation, remember we talked about that last time? If someone has VFib and their ventricle basically starts quivering and you're not getting any sort of blood pumping out, you no longer have a pulse at that point. The brain is the most important organ. That's the first one that starts getting damaged with deoxygenation. And so the brain is always going to require blood flow so that it can get proper amounts of oxygen levels. And then all the other organs, the blood flow is going to mostly depend on what's going on, like the metabolic needs. For instance, if the digestive tract was, if you had to have more blood going there because you just ate a meal, that more blood would be shunted through your digestive tract. If you had to metabolize, like drugs or metabolize things through your liver or kidney, then more blood would go to those regions as well. Skeletal muscle, if you're exercising, more blood is going to go to your skeletal muscles during exercise. And it's all going to be based off of vasoconstriction, vasodilation, as well as precapillary sphincters. Those precapillary sphincters are what basically turn on direction or the flow to certain regions and turn off flow to certain regions, depending on the need. So right over here, those precapillary sphincters are relaxed. So you have blood just basically coursing throughout all the capillaries. However, if those precapillary sphincters constrict, you basically block the ability for blood to go into those capillaries. Okay, so that can happen if you don't need blood in those particular regions. Here's just another image of what those look like. So you have your vein. So let's start with your arterioles here. So you have your arteries, which eventually turn into arterioles. And those arterioles are going to play a huge role in like constriction and dilation to allow blood to enter into the capillaries. Once they get into the capillaries, you do have those precapillary sphincters that can also help to control the direction of blood. And then once the blood gets into the venous system, that's when it goes back towards the heart. You also have anastomoses. And anastomoses are going to basically allow for blood to continue to move. Like for instance, if you had like an injury, if you had an injury in your radial artery, you have an anastomosis with your ulnar artery as well. So the ulnar artery would still be able to bring blood to that region. As a matter of fact, we have a cadaver here at the lab that had coronary artery bypass using the radial artery. I don't know why they used the radial artery instead of the greater saphenous vein, but they did. The person was still obviously able to have blood getting to their hand because of anastomoses. So that's going to be a huge benefit for providing blood, even if you lost a couple of these vessels due to injury or even due to vasoconstriction. Now, in terms of blood flow when you're resting versus blood flow when you're digesting, this is going to be at rest. So blood is going to be parsed out depending on the importance of the organ. So the cerebrum is going to always have a lot of blood going towards it. Muscular system and then digestive system have roughly the same amount of blood, as well as the renal system. And then cutaneous, so that's going to be like skin, and then coronary, which is going to be the blood going back into the heart through the coronary arteries. If you start exercising, you're going to have more demand in your muscles, right? So your muscles, so you can deliver enough oxygen to be able to perfuse your muscles. You're going to have more blood getting siphoned off into those tissues. Now, here's a fun question. Why do we cramp if we exercise after eating? If you start exercising after you eat, right? If after you eat, you're going to have higher demand of blood in your mesenteric system. You're going to have blood having to go there to be able to absorb nutrients from your meal. And then all of a sudden you start exercising. Now blood is going to get shunted off to your skeletal muscles. And now you started taking away blood from the GI tract. You start getting buildup of lactic acid in those regions, and that can start resulting in cramps. So that's one thing to keep in mind. Don't exercise after eating, or don't go swimming after eating. That was what I was always taught. Let's see, moving on here. Let's see. So let's talk a little bit about arteries before finishing up here. Arteries are going to have thicker walls. We already talked about that. One of the biggest differences between arteries and veins is going to be that really thick tunica media, which is where you find the smooth muscle. So those thick walls are going to be able to help accommodate that higher pressure. Now remember, the aorta is like the first entry point of the blood into the circulatory system, right? The peripheral circulatory system. And so a lot of pressure is going to be taking place in the aorta as the ventricles contract. And so to be able to accommodate that, those vessels are going to have really thick walls. They're also going to be very elastic, so they can accommodate the changes in those pressures. So they're going to be able to actually expand and contract as a consequence to the change in pressure. And then this is a good image that helps to show you the difference between an artery versus a vein. They have the same layers, but they're going to be a little bit different. The lumen of the artery are generally going to be thinner than what you find in the vein. The walls of the artery are going to be a lot thicker than what you find in the vein. And overall, the veins are just going to be a lot larger than arteries. The biggest layer in the artery, that's going to be the tunica media. And that is basically it on that slide. And then in terms of the unidirectional blood flow, those valves are going to play a really important role in allowing blood to move against gravity. Now, in terms of distance, the venous system is the furthest away from the heart, right? So in other words, the blood pressure is going to be vastly reduced, and on top of that, blood flow is also going to be a lot slower. And so for that, that's the reason why we need to have these valves to allow for unidirectional flow. When your skeletal muscles contract, pushes the blood up, the valves close, and then the blood doesn't pull back down. So that's how you get that unidirectional flow. So here's a good image that kind of shows what that looks like. You have the valves open, you have muscular contraction, the blood is able to move. This is also one of the reasons why a patient with deep vein thrombosis, this can result in deep vein thrombosis if you don't flex your muscles, if you remain seated for too long. I talked to you guys about my pulmonary embolism story. Pulmonary embolisms are very common for people who travel long distances on an airplane. If you stay seated for way too long, all of a sudden you start getting blood pooling in your lower extremities, and then that can increase your risk for deep vein thrombosis, which can also result in pulmonary embolism. Bless you. That's why if you take a long trip, they always recommend that you try to stand up, get up, maybe like stretch your legs a little bit, or you could just like try to flex your calf muscles, just so you can help increase blood flow. This is what happens if you get damage to those valves. You can get things like varicose veins. These over here, these are called telangiectasias. These are going to be varicosities over here, and they can be very unsightly. Telangiectasias are actually kind of interesting because you can treat them with a procedure called sclerotherapy. So let's watch a little video on that, and then we'll close out after this. And it's really interesting. If you guys are on Instagram, and if you have a strong stomach, follow Medical Talks. Medical Talks will show you all sorts of crazy videos, including that video that I just pulled up. I just saw that video this morning. I was like, oh, that's cool. I'm going to be talking about that today. So follow Medical Talks. They also show really brutal wounds. They'll show before and after procedures. They'll show different types of infections and stuff. So it's a really cool page. And then you can show your friends when you guys are at the dinner table, so you can ruin their meal. All right, guys. Good job today. I will see you all next week.